Welcome, everyone. I'm Carmel Shafar. I'm the Executive Director of the Petrie-Flom Center for Health Law, Policy, Biotechnology at Harvard Law School. I am thrilled to welcome you to COVID-19 and the politics of reproductive health. COVID-19 has been a major health law and policy story, and we have been approaching it in a variety of ways, especially in terms of a global view. I would recommend that you all check out our blog, the Bill of Health. If you Google Petrie-Flom and the Bill of Health, it should come up, for an excellent digital symposium brought together by our Senior Fellow in Global Health Rights, Alicia Yamin. We have about 30 entries from different countries looking at the impact of COVID-19 on rights, on governmental structures. Speaking of which, in the fall, in September, we will have an event looking at the symposium and reflecting on what has changed since that symposium was launched in March. You might be asking, how will I get notification of that event? If you are not yet signed up for our newsletter, I highly recommend that you do so. It's the best way to find out about our events. If you go to the Petrie-Flom website and scroll down, there's a place to sign up. The newsletter only comes out twice a month, so it is not a burden on your inbox, and you'll be able to find out about events like the event supporting our symposium on the impact of COVID-19 on global rights, as well as a variety of other events coming up. For example, one looking at the American regulation of psychedelic drugs as treatment for mental health, or looking at the availability of add-on procedures for IVF. Highly recommend that you sign up for that. But I'm also excited about this event because one other area of focus that we've had for the last month, but also in all of our work, is looking at the impact of COVID-19 on reproductive rights and sexual health. We started this 2 weeks ago with an event looking at June Medical Services, which was the most recent American Supreme Court case on abortion access, but also talking about how COVID-19 has impacted access to reproductive rights, to sexual health. This event is taking a much more global view, which is going to be very intriguing. I am not a global expert, so I am going to very quickly turn it over to the woman who is at the Petrie-Flom Center, my colleague, Alicia Yamin. Please take it away.
Thanks very much, Carmel. Thanks for that lovely introduction and setting the stage. And I want to welcome all of you to this webinar. And really, I'm also thrilled because we have an incredible panel of speakers. I just want to say another word of introduction based on the Global Symposium. There was, I should say, their Pfaffensblog attempt to do comparative analyses of what was going on with COVID-19. Our Global Symposium focused somewhat more on health, but it was important for us to take that comparative approach because, as opposed to, say, databases of laws that have been generated around the world since COVID broke out, what is really critical to understand as a scholar and practitioner, and also as the person who is affected by laws, is that these are not self-applying, that especially, for example, in an area like sexual and reproductive health and rights, the law is not a formal set of rules. It means so much more outside of those formal rules. There are informal practices, informal rules, as you'll hear from many of our speakers today. So the idea behind this, the comparative approach we took in the symposium, was to begin to get at that. And since sexual and reproductive health and rights is an area that has been particularly affected during the COVID-19 pandemic, we wanted to have an event that focused specifically on the ways in which in the short term services may have been displaced or affected, funding reallocated, and sometimes not, sometimes innovative solutions developed, and also look more at the potential long-term implications of sexual and reproductive health and rights changes, whether in terms of disruptions of legal and social mobilization by movements, or in terms of what the effects are on women who may end up having children because they don't have access to contraception, and the like. So I'm really delighted today to have 4 speakers from different countries and really different regions of the world. And I'll introduce each of them very, very briefly, although they each have long bios with which I could introduce them. So our first speaker is Ruth Fletcher, who's a senior lecturer in medical law at Queen Mary University of London. She's published incredibly widely on reproductive rights and is an editor on the Feminist Legal Studies Journal. Ruth, take it away.
Thanks so much, Ali, and wonderful to be here with you all and to get a chance to learn from all the different contexts and just see and talk to each other. So I thought I'd start with perhaps some good news about one of the responses we've had in Ireland to COVID-19 in the context of sexual and reproductive health. And that's that since April this year, we've seen remotely administered abortion integrated into the public health abortion service as a result of emergency responses to COVID-19. So what's interesting about that, lots of different things are interesting about it, but I guess one of the things is that, you know, that's less than 2 years since the constitutional referendum in May 2018, which was the removal of this protection of the right to life of the unborn that then set in train the legalization of abortion. And so we've gone to a system now where we have remotely administered abortion as part of the public health service and not as a predominantly illegal activity, which is what it had been. So the crisis has enabled that. There's been some innovation in that regard. And the means by which that was achieved, there's 2 different key stories about this. One is the kind of formal legal story, which tends to be foregrounded, and that's that it was a change of interpretation of the legislation rather than a formal legal measure that was adopted to enable telemedicine in Ireland as part of the public health service. So the minister decided that examination in the abortion statute could mean examination at a distance, examination over the phone or examination by video call, and didn't require physical presence, which is how it had been interpreted before. So we've had, things that were thought to be legally necessary have turned out to be unnecessary in the context of the crisis. And that is something that I think we can take forward in all sorts of ways. But more importantly, the story that's backgrounded, and it's probably obvious to all of you here, is that wouldn't have been possible if it hadn't been for decades of feminist labour in making abortion drugs available by telemedicine remotely, and all that illegal practice in importing pills, all that comradely practice of activists in the north of Ireland importing pills, bringing them across the British border in Ireland, making them available, supports from the Abortion Support Network in England, obviously international level support in terms of Women Help Women. So there's an extensive range of feminist labour that has gone into making it possible that this crisis then was able to bring that work out of the shadows and into legally recognised public provision. So there's an interesting way, I think, then, that the crisis is reproductive in the sense that it has picked up on existing crises and the responses to those crises and innovated with that. And part of our challenge then is to take some of those good things forward. But obviously, part of the reason why I'm emphasising those good things is because there are so many difficulties still with not just with the abortion service, but with sexual and reproductive health more generally. And so we want to hold on to that feminist labour because we need it to address the problems with the limits of the law, not least the fact that particularly vulnerable cases are not being dealt adequately by the 12-week limit. And so that again emphasises the way in which the abortion law is not accommodating particularly vulnerable cases, particularly where there's been diagnosis of fatal anomalies, or severe anomalies rather than fatal anomalies, for example. So again, that highlights something that's happening with the crisis, in the sense that are the ways that our hospitals and our public institutions have become a key site of concern with clusters and outbreaks with COVID-19 and the implications for people that are living in institutionalized care, as well as for those who are working in that institutionalized care, often when it's homes for the elderly or homes for disabled people, again often women workers being rendered vulnerable through the crisis. So in Ireland, what we're seeing is the ways in which the COVID-19 is exposing vulnerable populations, particularly I'm thinking at the moment of people living in direct provision centres. So for the last 20 years, Ireland has had a system of detaining asylum seekers and institutionalising them so that they get bed and board, but they get a very basic allowance of €20 a week, which when you think the welfare payment is 350 a week, then you can see how little it is. And they're not allowed to cook for themselves. And obviously in the context of COVID-19, they haven't been able to socially distance appropriately. And so they're even more vulnerable then to outbreak. And so actually just recently, we've seen one of the direct provision centres in Kerry, in Coercive, the residents have gone on hunger strike to seek removal from that centre. And so in the context of Ireland, what that does is it mobilises a history of dealing with social problems through this suffocating type of welfareism. And so our big challenge is, how do we turn those suffocating welfareisms into welfareisms that can enable? How do we draw on feminist labour and the value of social reproduction to try and do some transformative work there? And that's where a lot of the support work is focusing then on supporting people in direct provision at the moment. The third kind of key problem is ways in which then we've seen coercive policing, the move to more coercive policing in the context of COVID-19, how that's had an impact, particularly on those who are claiming welfare payments, for example. So typically in Ireland, the system of policing has been a sort of policing by consent, but again, one of the former crises that's been rendered perhaps visible by current emphasis on coercive policing is the invisibility of lots of coercive policing against travellers as a minority, for example, and failures in accountability about policing. So there's very little data, for example, on detention through policing, on injury and death in custody, for example, historically, so in a policing context. And so that mirrors problems with the institutionalized structure, which has played out in terms of obstetric violence and institutionalized of problem women in that way. So, but in terms of the policing initiative, one thing that we've seen develop through COVID-19 with coercive policing is around the sharing of data then as well, that has made people in receipt of child benefit, for example, as a type of welfare payment, has made them vulnerable. So this week, it's been reported that we've seen 100 families have their social welfare payments stopped for travelling abroad on holiday. And this, the free legal advice centres, etc., are reporting that that is illegal in the sense that it's not authorised by law. And we're also concerned about the way that the data is being used. That data at airports shouldn't have been transferred to social welfare. So, and that's having an impact on families drawing down child benefit as well as other sorts of welfare payments. So those are the three key points. Good news about abortion telemedicine and feminist labour that's drawn on, but lots of problems around hotspots with particularly vulnerable populations, such as indirect provision, and lots of issues around the ways in which coercive policing is targeting welfare, discriminatory targeting welfare recipients, for example.
Thank you so much, Ruth. So now we're going to turn to a very different context where you'll see some of the same issues and others as well. Camilla Danella is Executive Director of the Center for Social Sciences Research at the Catholic University in Lima, and also a senior researcher at the Christian Michelsen Institute in Norway, where she has participated in the coordination of various projects on sexual and reproductive rights lawfare. Camilla?
Thank you, Alicia, and thanks for the invitation and the opportunity. So we're going to talk about Peru, and perhaps you already know, Peru seems to be well placed to respond to the COVID-19 pandemic as a country that has achieved sustained economic growth for many years and moved towards achieving universal health coverage. However, Peru has one of the highest transmission and mortality rates of COVID-19 worldwide. By July 26, Peru, that have more or less 30 million inhabitants, have more than 375,000 confirmed cases and 7,500 confirmed COVID-19 deaths. This has happened despite the state of emergency declared by the government on March 15, when there were not deaths and really few cases. The lockdown and the collapse of the health system has created major barriers to access to health services in general. Outpatient services were closed. There has been some efforts to implement telemedicine for some services. This is not possible for most of the population in a country with only 40% of the households have access to internet, and only 5.9% of the households in rural areas have access to internet services. Besides, people cannot get drugs, including contraceptive methods, through telemedicine. So they have to pay and go to the pharmacy, and that is also restricted. Another major issue is the lack of health personnel. Health workers are getting infected. Some of them are dying. Community health workers are also getting infected and dying. And in rural areas, there has been reports of health facilities that have been abandoned by the health workers. So we also have a problem with the capacity of the health system even to provide care. Peru has also reported one of the highest percentages of excess mortality. Only Lima reports 23,200 more deaths, which means an excess of 289% if we compare with the previous year. And one problem is that there is not an analysis of the death cause. So all has become COVID. COVID has become a really contested issue. And there is a lot of conspiracy theories saying that all the deaths are COVID, and the government has been covering the impact of COVID. Politicians, we are in an electoral year. Actually, we are going to have next year general elections. They are asking for a truth commission to analyze the COVID deaths, but there are not analyses of the other morbidities and how many of these deaths has been possible to prevent. So, for example, in the case of maternal mortality, Peru has been reporting a sustained decrease in maternal mortality over the last year. However, if we analyze the number of maternal deaths till the week 27, that is the available data, it's possible to see that in 2020 there has been an increase, especially since the week 16. So by 2020, we are reporting 160 deaths compared with the 2019, the same week that were 147 deaths. For sure, we need a deeper analysis of this and to try to know what is going on, but we need more than just speak on exit of deaths to see what are these deaths about and to try to understand what is going on there. Within this context, there has been some informal rules to block access to sexual and reproductive health services and supplies. There has been report on health facilities, be it hospitals, specialized hospitals in Lima, for example, that are denying the access to emergency contraception that is legal and is part of the kit for victims of sexual violence. The arguments provided by the medical doctors is that they decide when is an emergency. They are only going to provide this when there is an emergency. And the other argument is that the sexual and reproductive services are still closed because of the pandemic. This is happening in a country that has reported 915 women as missing only during the lockdown. The government has been doing almost nothing to tackle this beyond sending some text by message saying that you are in risk, please report. The implementation of emergency lines to call, and showing a general concern of this in the political discourse, but still nothing really to tackle the protection of women and girls. So in a country where sexual and reproductive rights has been historically neglected, an emergency situation as the one created by the COVID-19 is just showing the state of society priorities. There is a need to develop responses that are sensitive to gender, sensitive to the needs of women, to the needs of sex workers. There has not been any specific measures to take care of sex workers. There has been some media reports on the situation of sex workers in Lima town, but nothing really to try to protect them. And besides, I think we also have to consider what is the long-term effects of this for sexual and reproductive rights. As I said before, Peru is in an electoral year, and sexual and reproductive rights has been used before as an arena to gain votes and to gain political support. In a situation of a crisis as the one that we are under still in Peru, with this big load of COVID-19 cases, and without a clear political leadership, we need to be afraid that sexual and reproductive rights can be again at the core of the political debate in the next election, and to see what is this going to mean on the political proposals that the politicians are going to do the next year. So, yeah, I think that's what I want to say. Thank you.
Thank you very much, Camilla. So now we're going to go to yet another region and hear from Nerima Were, who is Acting Deputy Director at Kellen, Kenya, which is an NGO that has brought some of the most important litigation relating to sexual and reproductive rights, not just in Kenya, but in considering the implications and norm diffusion effects for all of East Africa. So Nerima, I'm delighted to invite you to do your presentation.
Thank you so much, and thank you so much, Ali, and the previous presenters. I think now I have really easy work of building up from what you've just discussed, and unlike Ruth, there's not much good news from the Kenyan front, but there are quite a few lessons to be taken from the pandemic. So I think there's two things to appreciate: how the pandemic itself and the pandemic response have affected reproductive health and rights. And while there was initial understanding that this pandemic, unlike the Zika pandemic, might have some biological implications for women and girls and their reproductive health and rights, the response has not in any way been gendered or contextualized in a way that might guarantee health and rights in this period. And some of the key measures of the response that have been quite problematic, particularly for access to services, have been the implementation of a curfew since March. It's still ongoing. So it was initially from 7 p.m. to 5 a.m. It's now from 9 p.m. to 4 a.m. But there is no clear guidance on what is supposed to happen within curfew hours, which then means a lot of people who need access to emergency services within curfew hours have been criminalized for trying to seek those services. Some of the early cases that we had in the country, within the first week of the curfew being implemented in March, a man was killed from police brutality trying to ferry a woman to hospital to seek maternity services. Further, we've had an interruption of maternity services, which is supposed to be addressed by both national and county governments. So in Kenya, we have a devolved system of health, which then means primary healthcare is with county government. We have a national policy on reproductive health and rights, particularly during the COVID-19 pandemic, which specifies what is supposed to happen during the pandemic, which is a good step forward for us. So it says access to maternity services has to continue, access to contraceptives has to continue, access to post-trip care services have to continue, but it doesn't say how this is supposed to happen during curfew hours, despite the curfew being in place. It shifts most of the maternity care, like antenatal care, to telemedicine. It doesn't specify how women are supposed to access either telephones if they don't have access to them, or practitioners if they need obstetric care. And it assumes that everybody has the same level of access to information. So it was developed at ministerial level, at the national government, has not been disseminated within the counties or within communities. So one of the cases that we've had so far is a lot of women are shying away from hospital for one of two reasons. Either they perceive that they will not be able to access facilities, or they actually won't be able to access facilities. We've had early cases of women being turned away because they don't have a mask, because they don't have access to sanitizer by healthcare practitioners, or healthcare facilities not having the necessary personnel in place because of the pandemic. So then this has meant that we have lowered the number of women being able to access skilled birth attendants. We're having less and less births happening within facilities. I think one example is Mbagathi Hospital, which is one of the key maternal facilities in Nairobi County, has gone down from 30 births to 7 births within a unit. And it's not to suppose that less women are giving birth, it's that less women are giving birth within facilities, which means they are giving birth somewhere, just somewhere not as safely. Further, there's been an impact on access to vaccines in this period, with less and less people being able to access free and compulsory vaccine that is required by the state. Lack of information has been a very huge issue because the government has put policies in place but has failed to disseminate them, has failed to explain what is supposed to be done to continue to access services despite saying there's been a non-interruption. So we're continuously receiving praise as a country for having a good pandemic response, but we haven't in any way gendered how that has impacted on different people and how people don't have the necessary information to ensure they can access other health services. Sexual and gender-based violence, there has been an increase in violence within the home. And this is one of the issues where it's a deeper marginalization. So it's not to say that we didn't have these issues before, but the pandemic response has worsened it. So we don't have shelters already, government shelters already. Now, in the pandemic whereby women do not have access to NGOs which normally run shelters, some of them are shutting down because of a decrease in funding or because of measures that have been put in place, such as stay-at-home directives, which then means for a woman who is now suffering violence, if it happens during the curfew hours, if she tries to leave the home, she's likely to be arrested or brutalized by police. If she does stay within the home, she continues to be violated by who is violating her. And if she does manage to leave the home, access to a shelter has been limited because most of the organizations who provide these services might not be operating in the same way as they were prior to the pandemic, and the government doesn't provide these services. Further, there's no clear directive on how post-rape care services can be accessed during curfew hours, and if they're available. Many people, not necessarily women, are shying away from facilities only on the perception that they will get corona if they go to the facility. There is no guidance on how this is being transmitted and how you can protect yourself and how the facilities are still available to you. I think there is good news to be spoken around in that we were already in the process of discussing universal health coverage in this country. We do require essential SRH services. this has been a continuing discussion, and I think this pandemic has made it quite obvious that if we do not put in place certain packages of care, then we will continue to make certain communities more vulnerable and deeply marginalize them. Whether or not we push forward in terms of universal health coverage or any other model, we will continue to make certain populations more vulnerable if we do not have guaranteed services, and reproductive health and rights services are such services. I'd like to finalize here, but just to note that Kellen is currently in court pushing for the right to information. I think one of the things that we felt have gone poorly is in terms of providing information to communities during this pandemic period, information that needs to be provided proactively and information that needs to be provided when sought. So that's a continuing discussion within the country. And thank you so much, Ali and colleagues.
Thank you so much, Narima. Now we're going to go back for our final presentation to Latin America, which I think has a slightly more positive story in Argentina than Peru with respect to sexual and reproductive health and rights, although it's mixed. Paula Vergallo is an associate professor at of law at the University Torcuato de Tella in Buenos Aires, and she's also extremely highly published in the area of abortion rights and reproductive rights, not just in Argentina, but on legal mobilizations throughout Latin America. Paula?
Thank you. Thank you, Ali. It's a pleasure to be here and with you and my colleagues here. So I have a presentation divided in 3 parts. I want to first give an introduction to the situation of gender issues in general and the feminist agenda until last March, because important things had been happening in the country. I then want to give you an overview of what has been happening in the last 4 months, both at the national level, but within Buenos Aires and the province of Buenos Aires, which are the jurisdictions most affected by COVID-19. And if I have some time, I will give you some basic ideas of the challenges ahead. So, starting this year, we have a new government in power and an unprecedented presence of women in power. We are actually harvesting the work of 3 or more decades of feminist mobilization in Argentina and the generational change and escalation that you have probably heard about with the Ni Una Menos movement and the 2018 debate of a new abortion law that we lost in the Senate for a few number of votes. But we are celebrating, and we were celebrating this last March, the first Congress with parity, where the parity law approved in 2017 was put in place. We have a half and half national House of Representatives and a Senate. And we also have a new president and a vice president who is returning to power, and the first women to be in that position after having been a president, President Cristina Kirchner. But we were celebrating that the leadership of the country had made an important commitment last year during the electoral process to the gender and the broader gender agenda, not only about women's rights, but also LGBT people. So we were, in terms of the gender agenda, we were seeing the development and establishment of a new national ministry for women, gender, and diversity, and also an important ministry in the province of Buenos Aires, the biggest jurisdiction of the country. And the president had inaugurated the congressional year in the first week of March before we went into confinement, promising to send a new abortion bill, promoting modernization of abortion law in Argentina, and also promising to move forward into the confirmation of ILO Convention 190 on violence at work. And the province of Buenos Aires was seeing a similar process. So we got into the confinement policies and the lockdown in a moment in which we were expecting to have a new important debate moving forward after the 2018 conversation to reform our criminal code on abortion. The arrival of COVID. So we went immediately and very early into a very strict confinement system that has been in place until now, in which we are splitting the country in two very big different approaches. The areas outside the metropolitan area of Buenos Aires have been relaxing the confinement for the last 2.5 months. And in the city and the urban areas surrounding the city, we are still in phase 3 of the removal of the confinement, which is still a very restrictive situation. Some of us have not moved out of our houses or surrounding our places for the last 4 months. So in between, the government has worked in building the consensus across the whole country with all the governors of our federal system to prepare the public health system, the national and provincial systems, and also to interact with the private system to face the COVID crisis. The government has also strengthened social policies and financial transfers to the most vulnerable sectors, and they have developed a system to reach the informal population, which is very large in Argentina, through financial inclusion policies. The presence of women all over the preparation of the health system and reactions to women's demands in terms of violence, sexual violence, but also in terms of caring demand has been unprecedented. And after a shutdown, Congress has also started its operation and has been dealing with laws and challenges regarding the agenda for women's rights. Actually, the Senate has passed ILO Convention number 119 in the last month. And even in the city of Buenos Aires, the legislature of the city of Buenos Aires 10 days ago has passed the abortion guidelines that were issued by the government 2 days after the new president took office and the Ministry of Health was set up. So in terms of regulations, even during the pandemic, we have seen movement in the legislative body of the city of Buenos Aires, and the government has issued several regulations on different dimensions of the reproductive health rights. So in terms of the COVID reaction and health rights and reproductive health rights in particular, I would say that it has been integral insofar the government has taken care of the public health system and also the transfers to the most vulnerable women in our population. There is also an important regulatory dimension, and forward-looking, the country has not stopped the debate of new laws and programs actually from the perspective of Congress. I mentioned to you the approval of ILO Convention number 190 by Senate. The House of Representatives still has to consider it. There are several new laws regarding work at home that are being considered. We don't know if they're going to be moved forward. The Ministry of Women has developed the new national plan to fight violence against women, and they have just set out the information regarding the mapping of all the caring services across the country, which is a new, very important resource in terms of care services. There is also some data coming out from programs that the government had elected to keep from the former mandate, which is also a very important thing in terms of the stability of the reproductive health policies. We have an important program to fight adolescent pregnancies and non-intentional pregnancies that is providing information showing the difference between this year and last year demands of sexual and reproductive health services and other policies connected to the program. And there are also lots of regulations regarding access to online information for contraception, misoprostol, and the caring of women, of pregnant women and women needing to have their deliveries during the pandemic. So there are plenty of national and provincial regulations on all these issues, and like always in Argentina, the challenge is enforcement. But I want to say that the regulatory approach is unprecedented also, because it's more comprehensive. It's not only dealing with the basic maternal care issues, but it's also dealing with health issues and women's rights to health and sexual reproductive rights, with an approach that recognizes women's rights and their urgencies and their needs, and the need for them to continue receiving information and access to health service. So this is quite unprecedented, even if by now we see only that there is a formal commitment to those policies. We need to wait in order to have more evidence of how this is being implemented, how these regular commitments are being enforced. So the challenges ahead, the sustainability of all these policies. The country was undergoing an economic crisis, which is deepening and deepening every day, and it's going to be worse. So the challenges are, like always in Argentina, the promises of equality, the former promises of equality are too big. In practice, we don't know what is happening with the most marginalized group of LGBT communities, sexual workers, and the whole vulnerable population.
Sorry to break in, but we'll try to get to some of those issues in the Q&A. We have some questions from Twitter, and I would encourage people to use the Q&A function, and we'll try to get to those questions too. I have a number of questions for each of you and for all of you, but I'll ask them at the end so that people who have logged on can feel that their voices and questions have been answered. We have a couple of questions about what can be done and what has been done to attend to the sexual and reproductive rights of undocumented migrants, of sexual minorities, of especially vulnerable women who may be homeless. Ruth talked about women in care facilities. Narima mentioned sex workers, but what specific policies, regulations, programs are you aware of in your countries, or even more generally, that can be done or implemented for those populations? For example, getting undocumented migrant women sexual and reproductive health care. Well, I take it from the lack of response that, Camilla?
Yeah, I can say something on this. Okay, we have the situation with the Venezuelan migrants that has been coming, and Peru and Colombia are the countries that have been facing the biggest flow of Venezuelan migrants coming to the country. So there were already some concerns regarding the access before the COVID-19, the access by Venezuelans to the health services. And in the case of, there was a survey showing that they will have lower access, and in the case of women, lower access to contraceptive and sexual reproductive services in general. And in theory, they have the right to access, to deliver and that. But there were many barriers to access to that. So with the pandemic, there was a first report issued by some experts to try to give some advice to the Minister of Health, and I tried to provide them some advice, and Venezuelans migrants were a vulnerable group that was specifically targeted by the report, but still how this has been enforced and concrete measures that has been super weak. So health services are in crisis in general, and the living conditions of them are really bad, pretty bad. They work on overcrowded houses and without access to any kind of work. They were working in the informal sector as many Peruvians in the streets. They were losing the income, and they were excluded by the local government from the emergency help that they were providing, food baskets, and that they were not targeted because they were not in any record. So the government tried to target some families. The system was bad for Peruvians, but for Venezuelans were worse because they were not registered, because they are illegal in a way. So that makes it impossible to target them. So I think this is a big challenge, and I think we, as a country, are failing to them.
Thank you. I can also speak about this a bit. Thank you, Camilla. So not on undocumented migrants, because we don't necessarily have an asylum system within Kenya and mostly work within camps. It's more around sexual minorities. One of the biggest challenges that we do have is there was already an ongoing work to decriminalize sexual minorities in Kenya that has now been interrupted by this because the pandemic responses meant that courts are not functioning as they were. So we had a case trying to repeal the criminal law provisions that criminalize sexual minorities in this country that was ruled on last year, but was going on appeal. And now that has been delayed. So the criminal status remains at this stage, and the ability to then access services was already problematic. It has become more problematic, as I mentioned, because many of the organizations that now provide services to sexual minorities are not within the public health sector. It's normally private, or in most cases, it's going to be non-governmental organizations or civil society organizations. So not all of them are functioning at peak as a result of the pandemic response. There were directives to work from home, and in some instances, some offices were closed. And so sexual minorities are largely affected because they were already criminalized. And now with the pandemic response, they have limited access to their usual points of access to health services because they cannot rely on public health services. So with DICE centers continuing to work, it's not been as easy. So we are trying to conduct a study to get a sense of how impactful it's been on them, but it has been, from our preliminary findings, they've been impacted mostly in that they cannot access health services because where they normally would be able to have now either not working at peak or not operating in the way that they normally would. So that's like a huge issue. And then also there's now going to be a delay on the determination on whether or not they will be decriminalized in this country.
I could say something briefly, just in the sense that there has been a very significant migrant-led move for the abolition of direct provision, for example, in particular. And the new government, the new coalition government just in place, has committed to getting rid of direct provision, but the worry is that they'll replace it with something. That they won't get rid of it properly, or they'll replace it with something. So that's one key way that the sort of special measures problems that make people more vulnerable have been tackled. Otherwise, then it's about drawing down on equality and dignity provisions to try and get better access to services for the undocumented.
So I want to move on to a number of questions that sort of relate to the same thing, which is, can we really separate questions of safety of women in their everyday lives, physical and social safety, with reproductive health, sexual and reproductive health, and access to sexual and reproductive health services? Who would like to tackle that one? I have my own views, but I'll let you share your own views.
I could say something to get us started. I mean, I guess it's about the relationship between these different aspects of our social lives, isn't it? So the sense of security that one has in one's home, in one's neighborhood or community, obviously matters fundamentally to sexual and reproductive roles and to ability to access service there. So I don't think, sometimes strategically, because of different legal tools, we end up separating them perhaps, but I think we're always drawing down how they are related to each other. and how we need security in order, how security is a social good.
And how perhaps both the sexual division of power within the house and the increased exposure to intimate partner violence, which many of you mentioned, as well as the sexual division of labor, which means unremunerated care for women in the house, and lower, and often working in a non-formal sector, being laid off, not having money to pay for sexual and reproductive health services, all work synergistically in enabling women to enjoy their sexual and reproductive health, or impairing that enjoyment. Did you want to add something, Camilla?
Yeah, but I think that is something that is important, is also that what this is unveiling is this relation of these programs to target poor people, how they deal with poor people, and also the state violence against women that were, in many cases, the ones that have to go to make the lines in the street to receive the money and that, and how this has also put women in risk to get COVID. And they are the ones that are outside the hospital asking, waiting for the news from the relative and going to the pharmacies and that. So there is a lot of focus on how this kills more men. That's true. There is many things that make men more vulnerable to die because of COVID-19. But something that is interesting in Peru is that the epidemiological surveys that still we need to know more about the methodology, and that they're showing there are more women infected than men, and that's also is related with the care and all the things that they have to do in the streets and outside the houses to take care of the families and the relatives that are in the hospital. So
I think that's a really key point to underscore. In the beginning of this epidemic, we heard a lot about how men biologically, because of their ACE2 receptors, are more susceptible to serious complications from COVID-19. But socially constructed vulnerability of women is much higher due to working in the informal sector and needing to take public transport, which has been a major problem in Lima, and working in the public markets, due to being overwhelmingly the low, not the leadership in the health sector, but the nurses and lowly paid employees in the health sector, as well as a series of other reasons. So I think that's an important point to draw out about sexual and reproductive health. There are a number of other questions, but I know that our time is drawing to an end. So I want to ask a broad question to all of you, which is that many of these themes are common. The issues of the preventive isolation and confinement, and what that has done in terms of increases in intimate partner violence. I think it's fair to say that in sexual and reproductive rights, we have done a lot on legal mobilization and building normative scaffoldings, but we have done much less, focused much less on financing in health systems, and how priority setting and financing of health systems works so that sexual and reproductive health can be displaced. But the stories that you told here are quite different, which again underscores how laws work very differently in different places. And I want to ask you whether you think that some of the successes pointed to primarily by Ruth and Paula are due to you mentioned a lot of different factors. Electoral competition, say in the upcoming election in Peru, the feminist labor, Ruth, that had gone into these struggles for a long time, and the building of social movements to ensure that sexual and reproductive health is not ignored. The same thing could be said, I think, in Argentina. The institutional capacity questions, which have certainly been highlighted both by Narima and by Camilla, which of these factors do you think are among the most important in determining how sexual and reproductive rights and health and rights get treated during COVID-19 in your context? And I know that's a broad question, so you can take a piece of it.
Shall I go first? I think one of our key challenges is to center the economic value of sexual and reproductive labor, of that feminist labor, that we have to make life-making activities, that we have to make all the care labor, that we have to make that center, the reproductive economy, if you will, and make the productive economy accountable to that. So I think there's a big shift, you know, in how we draw the connections between all these different elements that you've identified for us, Ali. So I would see, yes, there are lots of differences in how the relationships get articulated, but we have those different elements across the jurisdictions. But there's something then, a thread running through it all around how we value sexual and reproductive contributions generally, and how we identify the economic value of that and look for that to be centered, and the rest of life to be accountable to it.
That's certainly true, Ruth, but that 2 years after the referendum passed, you have telehealth for abortion services is extraordinary, right? That some of the issues that have happened in Argentina since the pandemic are also to be applauded. What are some of the driving factors behind those positive developments that we should celebrate?
Well, I think that absolutely is about all of the valuing. There was a collective coming together across different elements of society that joined up with the feminist movement around the referendum. So being able to roll out kind of a feminist message more broadly is something that has worked. And then, so that is something absolutely to be celebrated. And that's why I think we need to foreground that and think about how to draw on it then to address the gaps that are there.
If I may join in, I think this is of course the result of a lot of mobilizing and networking across different places of Argentina, across different sectors, and it's multiple dimensions, but it's also a consequence of 40 years of democracy and the construction of a transition to a more peaceful way of living among all the different sectors of Argentina who had been fighting for decades. But still the challenges ahead, as I said, are related to making the country grow. Otherwise, there are no feminist or egalitarian policies that we can put forward that we can really enforce, reducing the distributional struggles that we are living and seeing in a country that has been reducing its capacity to growth over the last 70 years. So I think that the politicization of women is unprecedented, and I think that many of the things that I share with you are definitely the consequence of what women had made to get into politics and into power, into the larger setting, not only of the Congress, but also of the executive government and the private sectors, both in terms of civil society, but also the private sector of the country in the larger definition. But I still think that we all need to be part of the future of the country in terms of its economic growth and its distribution, because otherwise there's going to be still the law left in paper, and it's going to be impossible to enforce all these very dense promises in terms of redistribution too.
Camilla or Narima, did you want to add a last thing? We're almost out of time.
Yes, just quickly. So in terms of the question that you asked, just to note, I think there are significant gaps in institutional capacity in terms of strengthening a health system and a mechanism that can actually serve all the people in this country. And I think for us, what we've seen in the last few months, but also in the last decade, is really a shift in how we engage with our state. And I think that's what it's going to really be in terms of shifting our narrative over the next 10 years, how we engage in our state, because we do have a very paternalistic relationship with our state, in that a lot of what we've seen in the last few months has been a reintroduction of paternalism in Kenyan politics. And a lot of things are told to us are not explained, and there's very little accountability from the state at this stage, but it's not with the same citizenry that was there maybe 30, 40 years ago. So more questions are being asked of the state consistently. And I believe going forward, what is going to be pushing for the successes that we're seeing in Ireland and in Argentina will be not just the building of movements, but the building of social movements across the board without a silo of issues, such that we're talking about health systems being fit for purpose for everyone in this country in a way that doesn't just silo abortion as the one problem for us to make a moral issue, but really discusses the fact that we need to have access to choices as persons in this country. And that, I think, is going to be a conversation ongoing as we continue to unpack what it means to be in a relationship with your state and what it means to question your social contract and renegotiate that social contract.
Camilla, do you want to add something or not particularly?
Yeah, I think that it's what we are seeing in Peru is part of the institutional capacity to implement, but it's also, I think, that we have to reflect on how we has been addressing these issues in Peru. So I think it's also a result of a super elite technical approach to sexual and reproductive rights, in a way detached to broader social movements. So I think that is something that we need to consider. I think the thing of gender violence brought more attention because there has been more social movement rooted in organizations that other issues like abortion. And I think that is something that we need to reflect on.
Well, I think we're just out of time now. There were a few more questions in the chat for individual speakers who you can answer those directly. I do want to thank all of you very much for your presentations and also for the lively discussion. I personally believe that sexual and reproductive health and rights has, you know, a lot of people say that this pandemic has shown us a mirror of our societies, and I think it's shown both how far we have come in some ways in terms of expanding, as Narima said, the social contract to include issues of sexual and reproductive rights, and also how far we have to go and how this kind of false divide between rights in one small political sphere and the economic sphere that is closed off, that is becoming increasingly oppressively neoliberal, needs to be questioned through our advocacy and scholarship. So I'm just delighted that we could have this event, and I'm very grateful to you all for sharing your wisdom and experience. Thank you.
Thank you.
Thank you so much, Ali.